because I have another session at 11.
Good morning, everyone. I'm Dr. Shilpa, and I would like to start our instruction course on amblyopia therapy redefined, that is, newer modalities in amblyopia therapy. I have no financial interests to disclose. Um, so amblyopia, so far, it has been defined as a decrease in visual acuity caused by abnormal binocular interaction in one or both eyes as a result of patterned vision deprivation during critical period, for which no cause can be detected during physical examination and which in appropriate cases is reversible by therapeutic measures. So when we are evaluating and treating amblyopia, the factor that we mostly concentrate on has been a reduction in best corrected visual acuity. However, we also need to remember that there are other visual problems such as spatial distortion, positional uncertainty, reduction in contrast sensitivity, poor accommodation, poor binocularity, and stereopsis. This can lead the affected children to have reduced reading speed and compromised fine motor skills, thereby affecting their overall scholastic performance. Now, amblyopia over the decades has been treated with various modalities, that is refractive correction, occlusion therapy or penalization of the sound eye, and various drugs such as levodopa and citicoline have also been used. Of these, the patching of the sound eye has been the mainstay of amblyopia treatment. And it was so far believed that it cannot be treated beyond a certain age, that is beyond the age of 8 to 10 years or so. And also for many practitioners believed in the more the better principle, that is that followed long hours of patching and sometimes in some cases even full-time occlusion. However, this is met with many barriers such as poor compliance or reduced attention span amongst children and poor recovery of binocularity and stereopsis. So this brings us to today's talk. We'll be discussing various newer modalities of amblyopia therapy. I'll be talking about one of the novel modalities called orthoptic magnocellular stimulator. Then we have Dr. Sandra Chandramouli, who is a senior consultant in Department of Pediatrics, Arvind Eye Hospital, Coimbatore. She'll be telling us about the software Binox and its uses. Then we have Dr. Kaushik Murli sir, who is the Chief of Pediatric Services in Shankara Eye Hospital, Bangalore, and he'll be beginning this talk with details on Visuoprime vision therapy system. Then we have Dr. Damaris Magdalene, and she is the Chief of Pediatric Services in Sri Shankar Deva Eye Hospital in Guwahati, and she'll be telling us all about revital vision therapy. So over to sir.
Thank you so much, Dr. Shilpa, for having me as a part of this IC. Again, we've been research partners in the development of Visuprime, which is a made in India device and product for the world. I would like to acknowledge Aditya Goel, who's a senior colleague of ours from the Shankara College of Optometry, and Madan, who's the founder of Neuropy Solutions. I'm here to share how we've been using Visuprime to actually expand the boundaries of amblyopia therapy. As Dr. Shilpa mentioned, amblyopia, we all know, has been defined largely as a decrease in the visual acuity in one eye due to an abnormal binocular interaction in one or both the eyes. And we know that it's a result of pattern vision deprivation during during a very sensitive period, and in appropriate cases it is reversible. So all this is knowledge that we know of. And like Dr. Shilpa mentioned, occlusion remains the primary therapy that we do. When we went back and looked at some of our children who we had advised occlusion, we found that almost one third were not really compliant. You told them 6 hours, they would do 4 hours. You tell them 4 hours, they'll probably do 1 hour 3 days a week. That became a problem. The second we found was a number of them did not even know that they had to wear glasses. They assumed that they could either wear a patch or a glass, and they thought that both of that could actually help them improve their vision. More interestingly, we found parents, you'll see that one circle there. There's one child that used to be patched whenever they would sleep, because that was the time that the child would actually allow the patch to be put. So they did 6 hours of patching. Parents said we actually do 8 hours, but that is when the child is sleeping. So we looked at all of this, then we started looking at what was available in the market, and we realized that most devices or most solution at that point in time worked on the principle of the dichoptic stimulation. So in dichoptics, essentially what happens is that the images are superimposed when they are seen together, but however the dominant eye gets an image with a slightly lesser contrast, and this kind of helps it. I'll just show you some animations to kind of highlight how this very simply works. So you can look at it. The blue is supposed, imagine that to be the amblyopic eye. So over a period of time, gradually the contrast improves and it works. So our first initiation with computer-based therapy was with a system called the HTS. This was a US-based solution where you actually had a toggle that had to be put into the system to power it up, and it had multiple games that could be worked. It worked phenomenally well. Again, I'm talking of an era about 13-14 years back where pen drives used to be very expensive, and every month this toggle would disappear because somebody thought it was a pen drive and they would take it home. So we then had to ask them to courier an alternate pen drive all the way from the US. Over a period of time, of course, the company refused to supply because they thought we were pirating their software because the sheer number of toggles we were asking. That kind of forced us to say that can we build our own solution here. So we reached out to our partners and we built this system. Essentially what this does is it blends in diagnostics, it has binocular therapy as well as it also looks at perception based therapies. It's the entire gamut that it works on, right from accommodation, monocular function, monocular cues and binocular vision. It looks at stereopsis, anti-separation, and you can even do a random dot stereogram based on the system. Essentially this works both in premise as well as a cloud-based model. The patient is always under the direct supervision of the doctor or the therapist, and you have control in terms of choosing which module you want to trigger. And again, there's a lot of work that we've done working with children with autism spectrum that we've incorporated as a part of this. This also gives us, because it's sitting on a cloud, the flexibility of doing a part of it even out of home. So the patient can access this therapy remotely. The doctor can prescribe, monitor, manage therapy anywhere. And we've also looked at making it kind of a mobile friendly. So that's a work in progress that we are currently working on. When I say it's used across the world, it literally is. We have patients who are logging into the system from pretty much all across the world into using the system. So these are some videos that shows the kind of various activities that the patient actually does. So they can wear a polarized glass, or sometimes they can wear a red and blue glass where they're doing it as home therapy at home. But based on the dichoptics, it kind of splits it out and very simply does it. Monocular fixation in a binocular field is probably the cornerstone of most therapy that is done. So here largely it works on improving the sensory status. So this again is a short set of videos that shows what is happening here. So here again you see him trying to pick images. So it's like a gamified thing. It's not particularly intelligent, but it has enough variety to keep both the children as well as adults kind of interested, so they don't get bored very quickly. So you can keep playing around with the size, the speed, or you can vary the games also. And currently we're working on seeing that how can all the games be improved even in terms of how it works. Then we also use some amount of TV trainers. This again works on in terms of anti-suppression. So again, you look at the image with one eye being occluded with an image and through the filter, so automatically the person sees better. We've done stereopsis both for distance as well as for near. Again, here you can see this person, she's just clicking on the images that she sees, and gradually over a period of time the more evolved stereopsis can be measured. This again helps us in kind of understanding what the possible suppression scotoma is and gives us a surrogate of what the possible visual acuity is. So the first application we did and the first publication we had as a part of this was looking at adult anisometropes. So typically when we talk of amblyopia therapy, we say sensitive period 8 years, 9 years, beyond which you can't use. But because it was a new solution, our ethics committee refused to give us approval to try it out on children first. So we first said, can we try it out in adults? And we did try it, and we found it to work very, very well. So we found visual acuity improvement even in those who were not completely compliant with the entire therapy regimen that was there. We saw an improvement in contrast that happened very quickly. We saw a gain in stereopsis in about 7 patients, but again, in about 1/4 of them, we are not very clear how that mechanism works. We would love to believe that it is completely because of the solution that we built, but again, that is something that we don't know. Then COVID hit. In COVID, again, when we went back and looked at our patients walking in, we found a large number of them not coming into clinic. Almost 70% of patients and parents had actually discontinued therapy. That then got us thinking, saying, since it's sitting on, and that was the era where we were doing everything on Zoom. So we said, if everything can happen on Zoom, why can't evaluation and therapy also happen on Zoom? So here you can see that on a phone call it is being done. So earlier we used to give them access to our system using AnyDesk. Now we've stopped it because of data issues and privacy issues. But this is an example of how they use an AnyDesk. The patient is logged in. Our optometrist is with talking to them on the phone, actually seeing what they're doing, and you can pretty much get them to do whatever test that you were doing in clinic with them logged in from their house. Advantage here being the optometrist is actually seeing what the patient is doing, and you can very easily then modify what tests you want to do or play around with that part also. We did use this for therapy. This was done as a postgraduate research by one of our optometry students, where we looked at around 400 patients that were done. We found improvement in stereo acuity equivalent to those coming in clinic as well as those who were accessing it remote. We saw improvements in visual acuity, even visual acuity measurements were the same. Horizontal, vertical foria measurements, both in clinic as well as using the system remotely, were the same. We were able to get a reasonably good size measure of the suppression scotoma, as I mentioned, and that helped us look at what possible visual acuity they had. When we looked at both in-office as well as remote or supervised vision therapy, like we like to call it, we found both of them to be actually quite similar in terms of the outcomes. The advantage is that the patient has the convenience of doing it at the time that they want. They can do it without any time constraint. Disadvantage is they have to be motivated enough to do it. So when you have a solution and you know that you can access it anytime, there is a tendency that you may not prioritize it or you may not have the discipline of doing it. And there is a possibility of discontinuation. Again, all therapy can be done only using the software. It does not give you the luxury of being in office, where again you have multiple therapy. You can do certain manual tests to break the monotony. You can work on certain aspects using flippers, prisms, multiple other. You can use the entire Bernal equipment set that is available. And here the subject expert is hovering around the child's shoulder, literally seeing what they're doing to make sure that they're not guessing or not playing a game where they don't care. So again, children being children will treat it like a video game. They're okay if they miss a few things, but here you want them to concentrate on it. The disadvantage of in-office therapy is there are expenses, both direct and indirect. The parents also have to take off from work to accompany the child into clinic. So which is where this kind of expanding the borders using supervised remote therapy does work, where you can use, like I said, a platform like Zoom to enable access. So therapy again is given under supervision of an expert. There is no time constraint. Connectivity continues to be a challenge. Those of us at the conference have seen how connectivity can be patchy. So if you're depending only on an internet-based solution, you may have a challenge in terms of how it is. And again, you have the disadvantage of only software-based therapy. So this again is an example of what we've now started doing. So this again, you can see him on a Zoom. He's logged in. He sees the screen. He sees the patient on the other side, and he's kind of telling him. Unfortunately, the audio is not playing, but in that you will see him saying, please come forward, don't go too much back. And again, a multitude of activities can be done. He's not only looking at the response, but he's also looking at the distance that the patient has from the screen in terms of what they're doing. So that kind of works as a wonderful via media in terms of what we are doing. Is this instruction course even relevant? Is what we are talking even relevant? We did a small study where we reached out to among eye care practitioners in Karnataka, and they felt almost 55% of them felt that it was very, very feasible. And when we looked at awareness and attitude among them, almost 35% of patients we found, both among patients as well as caregivers, uh, the feedback we got was more than one third of them are compliant to conventional treatment. So there is a challenge there. Two thirds are not complying. 54% of them felt digital based treatment could work. 70% of them did prescribe some form of computer based video games that they thought would help the child. So we feel that this is something that has a great way forward. When you occlude a child, all you're doing is you're trying to improve their monocular visual acuity as the primary outcome. If you're happy with that, then yes, occlusion is more than enough. If you want to work on contrast, if you want to work on vernier acuity, the spatial correlation, perceptual attributes, contours, stereo acuity, and if you believe that amblyopia is a binocular condition that needs to be solved, then definitely you need to look at some form of binocular therapy. What we've attempted to do is build a solution that is adheres to the tenets of how exponential technology should be used in healthcare. We've tried to make it value based, where there is immense value to the patient as well as to the parent. The solution is tailored to the needs of each individual patient, and it allows immense customization both in terms of the clinical decision making we do as well as the practice that we entail. And this is a solution that is available on demand, whichever part of the world you may be. Once again, I would like to thank Dr. Shilpa for inviting me to be a part of this IC.
Thank you, sir.
If anybody has any questions, you can take it forward because he has another presentation. What's the cost of this?
Ma'am, we are not dealing with it commercially, so honestly, I have no idea. We were just the research partners. So Neuropy is the company that deals with it. You could reach out to them. So, but it's not Neuropy, Neurapy. So you could reach out to Madan from Neuropy. He would be able to reach out. But if I'm not mistaken, it hovers in the lower lakhs. About 3 to 4 lakhs is what I guess it is. Again, I'm not very sure.
And how much it costs to the patient?
Ma'am, it depends on what you want to give it to them for. So it's a SaaS model. So you can decide whether you want to charge them per session, you want to charge them for 120 runs. So that flexibility is there with you. So it's up to you how you want to drive it.
Is kind of a login, like you can, for every patient there is a login. And
Yes,
you
ma'am.
can do.
So that.
Can this be done on a mobile device or it's only with the desktop?
So currently we're working on a mobile device. So there are certain challenges with the mobile device because of the screen size. When you use a laptop or the desktop, you can actually trigger the camera on the laptop or the desktop and use that for multiple other assessments. So we, as a part of the solution, there also is a patent on doing a Brock string using this particular solution. So there you need the camera to know what the distance is, and that kind of helps you do that. But yes, we do understand that not everybody can afford a laptop, and that was becoming a barrier. So we are in the process of validating what we built for a mobile based platform.
Is there a tracking system, like how long they have done? Because you
All of that gets tracked. What exercises they've done, how long they've done, how many times they've done, whether there's a dropout, if the session. So the challenge with most of the overseas solutions is that once you lose the internet connection, that session is deemed to be completed. But here, because we know India and we built it for India, there is a lot more flexibility that is available there.
how often do you call these kids or the people, like what's the thing of the?
But typically this lasts for about 120 runs, so we usually tell them to do this for about 2 to 3 months and then come back in. By then we see quite a good improvement, and then you use the balance sessions that are there in form of a maintenance therapy.
Every time they have to log in, so you have to log in from our side and.
No. So if they're doing the home therapy, they have the username login. They directly go into cloud into their account. As a practitioner, your dashboard will show what has been done.
Okay, it's not you are asking, inviting them to a Zoom and all.
So we've started doing that now for a set of patients who say that, look, I don't want to buy a software, or I don't know how I can't understand it, or both parents are working. That's extremely common now. So they say we don't want to leave our child alone on the internet. So there we kind of offer this option of a monitor therapy, where through Zoom they log into our system, access our system. So we treat it like an in-office computer-based session. That's it. Right.
Thank you, sir.
Apologies. I have another talk that's clashing. Sorry about that.
And thank you, sir, for your talk.
So the next speaker will be Dr. Shilpa, who will be talking about
I'll be talking about orthoptic based magnocellular stimulation. So, this is a novel modality of treatment for amblyopia, and this has been produced and marketed by Carditech Private Limited in Bangalore. It mainly works via the stimulation of two pathways, that is magnocellular pathway and attention mechanism. Via these two, there is an increase in influx of top-down impulses to the occipital area, and it causes repeated foveal stimulation, thereby improving the visual acuity. So a little bit more in depth regarding this. So we know that this is a visual pathway, and vision is a complex process which starts in the retina and ends in the primary visual cortex area. However, there are different components, that is the what component of vision, which is mainly mediated via the parvocellular pathway or the P cells, and this generally deals with the form and the other structural components of the target. So this is mainly the what of vision, and it is processed in the inferior temporal cortex. Also, there is a magnocellular pathway which mainly deals with the where, that is positional, the position in space and the movement of the peripheral objects. This pathway ends up being processed in the superior parietal area. This the where part of vision is processed here, and throughout the pathway there is an intricate connection between both the M cell pathway and P cell pathway. So these are the different areas in the brain which deal with the following. So one of the important places is the posterior parietal cortex, which is a sensory motor integration center. This gets activated on seeing any kind of stimulus, and also during the generation of a saccadic movement or a prosaccade, and this sends impulses to the occipital cortex, thereby stimulating it. In addition, very close to the posterior parietal cortex, we have the attention area, which directs the fovea to the object of interest. So, whenever we either see something in a peripheral field of vision, what happens is there is simultaneous stimulation of different areas in the brain, that is occipital, parietal, and even the frontal regions of the brain. Also, there is close to this frontal eye field, we also have the motor area for hand. So when we move the hand to point at the laser light, we see that even this area is stimulated, and all these are interconnected, and all of these keep firing, and they send impulses to the occipital area, which in turn stimulates it. So basically what happens in this machine is there are flickering lights seen in the periphery of visual field, and when the patient moves his eyes to fix on that, a saccade is generated. When the saccades are repeatedly generated, the amblyopic eye is made to execute these saccades repeatedly and in different directions. So via the firing of all of these areas on both sides of the brain, what happens is there is an increase in impulses to the cortex area and the visual association areas, and this is said to overcome the foveal suppression and improve the vision and also binocularity, because it's happening on both sides. So indications. I will start with the most common indications. It was first started for different kinds of amblyopias, ametropic amblyopia, different kinds of anisometropic amblyopia, even strabismic amblyopia in some cases after the correction of the strabismus, and stimulation deprivation amblyopia in very few selected cases. Along with this, those people who have been successfully treated for squint cases, also it has been used in certain cases, and to reduce the recurrence of squint after surgery in intermittent exotropia by improving the focus and the control. Now these are some of the less common causes, that is to reduce the nystagmus, improve hand-eye coordination, and other problems in children with cerebral palsy. It has also been used in multiple cranial nerve palsies in very few cases. So when we see a patient, what we need to do is first we need to verify the diagnosis ourselves, that is via a detailed history regarding the duration and nature of the condition, a full cycloplegic refraction so as to prescribe the optimal optical correction. In case there is anisometropia, we can also consider contact lens for better compliance and for better effectiveness of the therapy. Uniocular and binocular vision requires to be recorded. Sensory evaluation, at least the basics of binocular single vision is worth 4 dot test, and stereopsis can be recorded. Investigations are not a must, but in case we have certain doubts regarding the diagnosis or we are unsure, it is always better to establish it via relevant investigations, in cases even maybe via electrophysiological testing and so on. So basically this is what the instrument looks like. There is a black shiny board with 9 LED lights. The peripheral ones are white in color, and there is a central red one. So there are different modes. The red one is always on, and the ones in the periphery keep flickering randomly. This green color corresponds to the laser light from the laser pointer which is given to the patient. So there's a video here, I'll play it. Okay, during a therapy session, the patient is made to sit at 1 meter distance wearing the optimal correction such that his eye level is at the level of the red light. Then he is instructed to quickly point at the light that is flickering using a laser pointer. This also helps with the hand-eye coordination. First, it is done with the amblyopic eye open and the good eye patched for 20 minutes. Following that, the patching is reversed and the good eye is treated for 5 minutes, and then there is no patching and binocularly we treat for 5 minutes. This is the first kind of therapy which involves an overt attention mechanism. After this, we do the second mode of therapy, that is, we ask the patient to not move his eyes and to concentrate on the central red light. As the white lights are flickering on and off, the patient is supposed to count them. Here we recommend about 300 times. It depends on the attention of the child and many other factors also. So the frequency, what we do is when the patient first comes for therapy, we give 1 session, ask them to take a break of 1 hour and give 1 more session. Following this, depending on the ease of the patient, either we give 1 session a day daily for 15 days, or if the patient is in a hurry or something, then we give twice a day for a week. Maintenance therapy requires 1 session a week later, then once in every 2 months. Usually beyond 6 months it is not required, and the improvement that has been noted will remain. At every follow-up we have to note the visual acuity, the presence of binocular single vision, and the improvement in stereopsis. If the patient has squint, we need to measure the magnitude serially. So our experience, this has been tried in a small clinical setup, so we have been able to try it only in 2 different centers on 68 patients. Actually, I think
Time is over.
no, I think the previous one has been added to this.
No,
I think she can
continue.
continue.
Okay.
We have time.
Yes, thank you. So the mean age of patients was 12 years, and we have treated a large age group of patients, that is 5 to 40 years. Most of the patients were female, and we have tried it on all kinds of amblyopias, but mainly we have had success with only anisometropic amblyopia. Strabismic we have had about 4 patients, and stimulation deprivation, that is children with unilateral pseudophakia, have been 3. Others include 1 patient with nystagmus and 2 more patients in whom the cause of visual deprivation could not be found out. This is a very rough calculation of the improvement in visual acuity. A mean of pre-therapy visual acuity was 0.62 logmar, and it improved to 0.128. At the beginning of therapy, only 4 patients had binocular single vision. Following therapy, it has been recorded in 48 patients, and stereopsis was very poor at the beginning of therapy. Less than 3000 seconds. Later on we saw that 48 patients had developed good stereopsis of around 120 seconds of arc, and 20 had developed up to 480 seconds of arc. I'll just run through these cases. This is one child who had strabismic amblyopia, that is, her right eye had a small esotropia and her vision was 6/18 parts. The other eye had vision of 6/9. Following the therapy, it has improved to 6/9, that is, in the right eye, that is only one line difference between the two eyes. Following this, we could not improve it further. Hence, we have posted her for a squint correction, and she has her motor alignment was also improved after this. Next is a child who underwent cataract surgery at a young age of 4, and following that he did not receive both optical correction or any form of amblyopia therapy. So after providing the optical correction, we saw that his vision had improved from 3/60 to 6/60, and following the orthoptic magnocellular therapy, it had improved even to 6/6, but however, over time it regressed to 6/9 parts. This is a documentation of that. This is like each session of therapy where we see that it has improved to 6/6, but there was a slight regression over some period of time. Coming to my observations, we see that when we begin the therapy, the amblyopia tends to improve rapidly in the first 2 weeks to about 6/9 or 6/12, but beyond that the finer improvement takes some time. Binocularity and stereopsis improves quickly even before the individual monocular vision. Hand-eye coordination in these children improves, and the improvements noted last for a long time. I have followed up a few patients up to 1 year. However, it is noted that a small amount of regression is sometimes there. Therapy can be started in very young children also, provided they are cooperative. So these are some of the other observations. Few children find this stimulation to be very intense and may cry during the therapy. This requires the parents to be reassured and the therapy can be continued. Then there is another phenomenon, that is jack-in-the-box phenomenon. Here they say that sometimes some children say that the letters are appearing and disappearing. So this is common during the initial parts of the therapy. After that it slowly decreases. Also, there is this phenomenon that right to left reading is seen to improve in most cases. Like when we are making them read from the vision chart, they read better from the starting from the right and moving towards the left, as compared to left to right reading. However, the reason for this is not yet known. And handwriting is also and also the scholastic performance is seen to improve in in children after therapy. That is, we can see this from a very satisfied mother of one of the children. It seems he has decreased making mistakes in the schoolwork. To summarize it all, orthoptic magnocellular stimulator is a novel technique in amblyopia management. It can be also tried in older children and adults. However, the success is much more in younger children. Apart from amblyopia, it can also be tried in controlling of strabismus and some children children with nystagmus, developmental delay and speech impairment also. We note a rapid improvement in the first few sessions, and later on it slows down. Sometimes there is a chance of a small amount of regression over time, during which we can repeat the therapy, and the improvement obtained overall lasts for a long time. Thank you.
Thank you very much, Shilpa. We can take 2 questions now, and then we'll go on to the next speaker.
The cost, ma'am, mainly the cost is per session. The instrument, it comes to around 1 or 1
you
to.
can give the contact of.
That is.
I think they've offered a cost of.
That's for the. We basically have to buy it once. That is all. Ma'am, I'll share with you the contact of the person.
Cost which he has given to me is 1.45 lakhs. The instrument.
That is up to us, ma'am. That we can vary.
Can be worked out in each place. It kind of varies from each. It's not uniform. So whatever works for you, you can do it in your place.
Wondering if you had any experience with autism, ADHD?
We have yes. This has been described this way, but I have personally not dealt with children with autism and giving this particular therapy. Most of my, since like I said, it was a small clinic where I was practicing in when I did this. Mainly it was anisometropic and few cases of strabismic amblyopia. This is it's Carditech Private Limited in Bangalore. I will share with you the contact, sir. Minimum vision. I have tried 6 by 60 set or yeah, 6 by 60 best corrected. I have tried beyond this only.
The initial setting when you do for the children, do they do it for few sessions full or just 10-15 minutes like that,
No, few sessions full. We basically ask them to come early in the morning when they are well rested, in a good mood and all that. Usually a parent sits with them during the session.
Okay.
And I used to follow them up every day, actually. Like I used to, once the session was over, I used to send them to get a snack or something. And once they are well relaxed, after about 20 minutes to half an hour, I used to see and I used to myself verify the visual acuity and other functions.
But only question about this, lot of things are going on for this sort of treatment. To call the patient for 15 consecutive days is the most toughest.
I used to call them during the vacation.
Only vacation?
Yeah.
Okay.
Yeah.
Thank you, everyone. Now I would like to call Dr. Damaris Magdalene to tell us about Revital Vision Therapy System. Thank you.
Thank you, Dr. Shilpa, for giving me this opportunity. It's not. Yeah, okay. So, very good morning to all of you. I will be talking to you about improving amblyopia in adults beyond occlusion therapy. I have no financial interest. Amblyopia, as we all know, is the leading cause for impaired vision in children and young adults up to 40 years old. There is about 2 to 5% of the world's population. It is basically a cortical deficit that leads to decreased vision in a healthy eye with stereo and binocular dysfunction, treated early during the critical period when the brain is plastic and considered untreatable after age 9. So the question is, can we improve amblyopia beyond the critical age? For this, we should know what is neural plasticity. Neural plasticity relates to the ability of the nervous system to adapt to change conditions in acquiring new skills, and these new acquired skills are retained for years. There is evidence for neuroplasticity. Visual acuity improvement in adults with amblyopia has been reported in case reports after prolonged patching or when the better eye's vision has been lost or degraded by age-related macular degeneration, cataract, and trauma. Large studies have been done in above 9 years, but they have found meta-analysis and RCTs demonstrated limited vision improvement in amblyopes older than 11 years, even with permanent or prolonged patching. So we have this PEDIC study who have found improvement in children from 7 to 12 years old and 13 to 17 years old, but it is not to that extent. We are in the digital world, that digital solutions, digital devices have a solution for amblyopia. Do they really work? Basically, we used to do this monocular occlusion treatment to improve monocular vision, but it lacks effective anti-suppression effect. Although typically amblyopia exists in a single eye, amblyopia should be viewed and treated as a binocular disorder, not monocular. In order to improve binocular functions, amblyopia should be treated binocularly. Stimulating both sides of the visual cortex with equal stimulus will improve stereopsis and binocular function. We have some reports which says the binocular treatment of amblyopia. What do they say? There is no level 1 evidence to support the use of binocular treatment as a substitute for current therapies for amblyopia, including patching and optical treatment. On the basis of the review of the published literature, binocular therapy cannot be recommended as a replacement for standard amblyopia therapy. PLOS was published in 2021. They also say the same thing. Binocular treatment cannot fully replace the traditional treatment, but to date, it can be considered a valid complementary therapy in peculiar cases. Between 2019 and 2024, FDA has cleared new products for patching, instead of patching in children below 9 years of age. We have this Novasight and Luminopia. But the only product which has been cleared by FDA in adults, in children above 9 years of age and adults, is the Revital Vision therapy. So what is this Revital Vision? It is a vision training web app that effectively stimulates the brain visual cortex. It's tailored to the patient's specific need. It's an algorithm-based cloud technology. You can practice it from the comfort of your home, easily prescribed by eye care specialists, ophthalmologists and optometrists. It can be performed at home by the patient's computer. You do it 3 times a week, 40 minutes or 30 to 40 minutes, 30 to 40 sessions, 2 to 3 months. Actually, the size of your laptop should be around about 14 to 15 inches. And the company claims that there is an improvement in contrast sensitivity of about 100%. Visual acuity improvement is about 2 lines, and also improvement in stereopsis and binocular function. So what is the mechanism of action? How does this work on the visual cortex? Revital's scientific vision building blocks are 4. One is the Gabor patch, neuronal lateral interactions, neural plasticity, and perceptual learning. What is a Gabor patch? Gabor patch are widely used in the field of neuroscience, having shown to efficiently describe the shape of the receptive fields of neurons in the primary visual cortex. They represent the most effective stimulation. And the next, what I said is the lateral interaction. Neurons in the primary visual cortex are selective for the size, orientation, and direction of motion of patterns falling within a restricted region of visual space known as the receptive field. So to characterize an image, visual processing involves the cooperative activity of many neurons, and that is lateral interaction, which is helped by in this Revital Vision. So they also did by experiments how to put the target to the patient. The response to the stimuli presented within the receptive field can be facilitated or suppressed by other stimuli falling outside the receptive field, which when presented in isolation fail to activate the cell. So these were the experiments, and they found just you give the target, it doesn't improve much then when you give the target along with the other flankers. So they found that the neural response with just the target alone, and the neural response with the flankers, and the neural response with both the target and the flankers gave more response. That is because of lateral interaction. So that is the second point. The third is neural plasticity, which I already said. That is the ability of the nervous system to adapt to change conditions in acquiring new skills. And these acquired skills, they persist and are retained for years. And the fourth thing is perceptual learning. What is this? Perception can be modified by performance, and visual performance improves with practice. Repetitive performance of controlled and specific visual tasks. Perceptual learning has been evidenced in a variety of visual tasks and has been found to persist for years. So actually, in order to effectively stimulate the adult visual cortex for high success rate, there is a need for patient-specific visual stimulation in a controlled and repetitive manner. So you enhance neural lateral interaction using perceptual learning technique. Repetitive performance of the specific visual task efficiently stimulates the specific neurons and effectively promotes spatial interactions among these neurons. Enhanced spatial interactions will reduce the noise level in neuronal activity, increase the signal strength, thereby improving neural efficiency, improving the contrast sensitivity function. Improved contrast sensitivity function results in improvement in visual acuity. So this is how they present the stimulus. So 2 computerized evaluation training sessions will identify the patient's cortical deficit using different stimulation types, activating different types of groups of neurons. For example, a meridional amblyopia resulting from specific astigmatism will be identified by the system when the patient is not responding to the GABA stimulation in a specific degree. So this is how they present the stimulus to the patient. So ultimately this software will identify the patient's specific cortical needs and it tailors it according to the patient's specific need. Algorithm tailor-based specific stimulation program using the GABA patch with lateral masking technique and also repeating it. Repetitive strong neural response forms new neural connections at the neurons in the synapse level. So it's a very simple thing. You show the patient 2 display, that is the first display and the second display, and the patient has to identify which one has the 3 GABAs. So if it is, and he is given a mouse in his hand, if it is in the first display he has to press the left button. If it is in the second display he has to press the right button, and if the system will provide the patient with the feedback in case it is an incorrect response. So the key strengths of this device is it level of the stimulation achieved with lateral masking. It's tailored to the patient's need and also ability to stimulate at effective contrast level. So we decided to evaluate the efficacy of revital vision in a challenging group of patients, adult patients with amblyopia following 6 months occlusion therapy. They did occlusion therapy with no improvement. So this was a study done on 45 subjects and our age of the patients were from 8 to 48. It has been published and the mean corrected visual acuity improved from 0.54 logmer to 0.32 logmer, giving about 2.2 lines of improvement in vision, statistically significant improvement. And I have purchased this in 2017, then the COVID had come. Until now we have done about 223 patients, and now I have followed up about 89 patients with a 5-year period, and there has been no regression to either they maintain the same vision and there is a 1-line improvement in 25 patients and 2-line improvement in 21, 3-line in 17 patients and more than 3-line in 1 patient. And again, there is an evidence of improvement in other diseases like nystagmus, albinism, keratoplasty, Stargardt's, and keratoconus. So there is a broad clinical evidence with 26 clinical studies, lots of RCTs and ongoing RCTs in different peer-reviewed journals. So this is the visual acuity improvement in adult amblyopias. About more than 2 lines improvement has been seen in various studies, and our study has also been included there. And also we have found improvement in albinism with bilateral amblyopia. The vision has improved from 0.38 to 0.18. And also there is improvement when you can try in keratoplasty, albinism and bilateral amblyopia, even in Stargardt's, congenital nystagmus. It's a retrospective study where the vision improved for about 2 lines. And this is a paper which is going to be presented in APOS, where it's a randomized study with in congenital nystagmus patients aged from 9 to 55 years. There is a significant visual improvement about 2 lines and more, and also improvement in stereopsis, and also we have studied in keratoconus patient. So whatever it is, vision, when you see vision improvement is, first is what happens at the front level when you capture the image, and that is what the industry does by giving us glasses. And then you have your processing unit which is at the cortical level, and that is where we have to work on, and that is where this revital vision works. So today the key to optimize visual function lays in addressing the brain as well as the eyes. Thank you.
Thank you, ma'am, for that talk. And now I would like to call upon Dr. Sandra to talk about.
Can we ask some questions?
Yes, we can take a few questions.
Few questions if there's anything. Yes, yeah.
So there's no regression of visual activities. Like how do did you follow them up? All the patients were remotely followed up or?
No. These are all only 89 patients who have, those who have come back after 1 year, 2 years, 3 years, we have seen, checked the vision. We are maintaining their records.
Supplement therapy which you asked them to do at home?
No, nothing. Actually, the basic thing is the strabismus should be less than 8 prism diopters. The visual acuity is 660, that is a standard. And I have tried even in optic atrophy patients of counting fingers 3 meters, where you make the patient come close to the screen and do it. I have also seen improvement in I didn't see improvement in visual acuity in nystagmus patient as vision per se, but the quality of vision improved. She's a PhD student. She said, no, I can see very nicely, but when you check the vision, it is the same, but the quality of vision had improved in these type of patients. Yes.
Device lately come up the digital device as an alternative for synaptophobe.
Synaptophobe.
And then his question is there an option to synaptophobe which is digital, right?
Yeah.
No.
I don't think
Yeah. But by the way, I think hardly anybody uses synoptopher. We don't use it. We treat it as an obsolete instrument. Yeah, that's it. Thank you.
Thank you, ma'am. Now I would like to call upon Dr. Sandra Chandramouli to tell us more about the Binox system of amblyopia therapy.
Thank you very much, Shilpa, for the kind invitation. And I think all the previous speakers have done a tremendous job of giving you a lot of insights into what are the newer therapies in amblyopia currently available. So how many of you are actually practicing binocular therapy in amblyopia? Okay, so very few hands. I think at the end of this session probably it may improve. And so definitely, before you start on any amblyopia therapy, the first thing that you should make sure is the refraction and glass prescription. So unless this is done, none of the amblyopia therapies will work. I think this is extremely important because there are many times when we have a wrong refraction and we think it's amblyopia. It takes a lot to get the correct visual acuity in a child. So unless you are very much, like you have a lot of experience, you may go wrong in the refraction and glass prescription. Traditional therapies, all of us has talked about. Occlusion definitely remains a mainstay. There are many conditions still where you will not be able to do the binocular therapies very well, especially in cases where there is a large angle strabismus, very dense amblyopias, very young child, less than the age of 6. You cannot expect to do a binocular vision therapy. So occlusion still remains, immediately after doing a pediatric cataract surgery, you may have to start on occlusion. That will be the step 1. The other therapies that we are talking about are in older children in mild and moderate degrees of amblyopia. Penalization and PEDIC guidelines can be followed to these. But definitely there are a lot of parents that we come across who are not able to do the traditional occlusion beyond a certain number of years. It is easy to do it in a preschool child, but the same in a school going child or in an older child, they do not get the time or the number of hours per day to be able to do the traditional therapies, poor adherence, and they have a lot of social and psychosocial implications of occlusion. When you ask them to wear the occlusion patch to school, it is not an easy job, and the child has a lot of emotional difficulties in doing the patching. And atropine definitely has light sensitivity issues. And another thing is, amblyopia per se does not address suppression, and you are not looking at binocular, you are not treating it as a binocular disease. And there are very few publications on how just occlusion, how can it, whether it can improve your binocular vision and stereopsis, to what extent it can improve, that we have to see. So definitely, as all the previous speakers have mentioned, it is not only an acuity loss. So once you stop thinking of amblyopia as just an acuity loss, then you will definitely look towards the binocular therapies, whatever mode it may be. Amblyopia goes way beyond acuity improvement. You have a lot of issues with depth perception, scanning and tracking, as how Dr. Shilpa has very nicely shown. The handwriting improves. There are a lot of parents who say, there was one parent who did binocular vision therapy with me, and after 2 months she said the kid is in 10th standard. That was the first time that the child has actually read the text by himself before an exam. Otherwise the mom used to read it out to him. So that was the fate of a 10th standard child, when for the first time before an exam, the child could actually read the text by himself. So depth perception, scanning and tracking issues, contrast sensitivity, motion perception, peripheral vision, are we even looking into all of these? So unless we look into all of these, we do not know whether we are treating amblyopia successfully at all. But the good news is, brain is, there is a lot of neuroplasticity in the brain. It does not end after a certain age. So how did these therapies come? It were all promoted initially as adult amblyopia therapies, where there has been an injury to the good eye. The people who are amblyopic are very prone to injuries, especially in the good eye, because of poor vision. And when that happens, there have been some reports of how the vision in amblyopic eye does improve even in the adults. So that's how the neuroplasticity studies came into play. So newer concepts look at amblyopia therapy as a binocular vision training, looking both eyes as a team. The goal is to break the suppression first and then to enhance the binocular capacities. Improved reading ability, better academic performance, and definitely better sports performance. So if there is an amblyopia, there was one patient whom I had who was an engineer, but his thing was in cars, and he had to look at the speed of the racing cars. He was employed somewhere in Germany, and that time he found a difficulty with amblyopia. He had a mild amblyopia, 6/12 and 6/6, but he could find a lot of difficulty with his line of work, because there is a difficulty in motion perception, and the speed at which they notice things is definitely lacking. So coming to binocular therapy using dichoptic stimuli, Dr. Magdalene has given a basic, there are two basic types of these dichoptic stimuli. One is the type of therapy which she has described, and I'll be talking about the binoc system. What do you mean by dichoptic stimuli? There are two independent stimuli to each eye, and that requires integration under binocular viewing conditions. So you reduce the contrast to the normal eye, then that will be matched to the amblyopic eye. And as the patient's performance functions improves, the contrast difference between the two eyes is gradually made equal, and the visual acuity gains follows the improvement in binocularity and contrast sensitivity and stereopsis. So all of them improve together. As you start recording the improvement in these patients, many a times you notice that the BSV and the stereopsis is what will improve initially, and that will be along with that the visual acuity improves hand in hand. So Binox is a cloud-based software for the management of computer vision syndrome and amblyopia. So they have various platforms. The diagnostics platform is called Binoptics, where you can do the assessments, and the therapy platform, you have the Binox Amblygo, which is for amblyopia. You have the Binox D-strain system, where you look at computer vision and digital eye strain and non-strabismic binocular vision disorders. And the other therapy is also there for improving the contrast sensitivity in like post-LASIK patients and post-adult cataract, especially with the premium IOLs. There also you find that for a few sessions, and every 20 sessions we call them back to the clinic just to see how it's going on. So the active graphic components can be seen by the amblyopic eye, and they are filtered out for the other eye, and both has to fuse to in order to see the details. And since it is games, it is very easy for the child to do this kind of program. It is not there is no difficulty in doing it. The children are not scared of the program, and they have to play these games for 1 hour at least for 5 days a week. So minimum of 5 days a week should be done. And in our experience, we see a good initial improvement. There will be some improvement in 20 sessions, and we do at least 40 to 60 sessions will be needed. That will be translating to around 2 months of therapy. So 2 to 3 months of therapy. Beyond 3 months, we do not advise them to continue, because some amount of once they do not improve between 2 sessions, they are unlikely to achieve a further. They reach a plateau for their capacity. So the company promises 2 to 3 logmar lines of improvement at the end of 2 months. So this is how it is. The comprehensive eye clinic examination in the clinic, followed by selection of right important is extremely important. Right patients in the thing, you rule out the presence of manifest strabismus, you rule out suppression, you rule out microtropias, and in the presence of strabismus it will not work. You have to align the eyes before you go into therapy. and enrollment followed by virtual training and then reassessment by the Binox optometrist and also by us in the clinic. So as I said, the inclusion criteria, it works very well in mild and moderate degrees of amblyopia, usually a BCVA more than or equal to 6/60 Snell lens. Foveal fixation is important. There should not be any tropia more than 5. You have to treat it with prisms and then you start the therapy. And all amblyopia patients willing for computer based therapy, they should have the requisite setup at home, or they should have somewhere where they can go and access a desktop computer or a laptop. So severe amblyopia, in our experience, it doesn't work very well. Eccentric fixators and those with tropia doesn't work very well. So you record the BCVA using Snell lens and logMAR, and you do an orthoptic evaluation, motor, sensory, all these parameters should be recorded baseline, do the 4 prism base out, dynamic and cyclorefraction, slit lamp biomicroscopy, fundus examination or OCT to document the foveal fixation, and then the correct diagnosis. It can be aniso, ametropic, stambismic, meridional, mixed or sensory groups. Following this, then you need to assess the size. So through the Zoom, when the Binox optometrist logs on to the patient's system at home, they do see the size of the patient's laptop and the desktop. It's calibrated, and there is a contrast calibration also done with the help of the red-blue negligence glasses. And at home, the patient along with the enrollment, they do get a measuring tape and a scale, so they can measure the distance at home and mark out. So they have to measure the distance visual acuity and near visual acuity in the area where they are doing the therapy at home. The room light illumination at home is also important. We advise them to sit in the same place every day because the computer has been calibrated for that. And heterophoria measurements and binocular vision with worth 4 dot and near stereopsis. So all these are recorded at the initial assessment, and then they are given a demo initially with the maximum brightness so that they understand it well. And after the demo, the settings are informed to the patient with the do's and don'ts, and every 10 sessions they get an assessment via Zoom with the Binox optometrist, and every 20 sessions we see in the clinic. And without completing the 10 assessment, the next set of therapy sessions cannot be accessed. So this is the monitoring. We can also see from our system how well the patients are doing at home, like the visual functions and your stereopsis, BSV, and whether they are doing the sessions every day, the time for which they are doing, all that can be seen by us. Just to have a, so this is not possible with the traditional treatments, like for compliance for patching, it's just their word for it or they write down in some notebook, where here actually we can see how well they are doing the therapy. And home visit guided sessions. So every 20 to 30 session we see in the office. There are some patients who do not have the requisite arrangement at home, then they can come every day and do also if they are from nearby. So here I think, yeah, can you please extend it? Okay. So this is the monitoring system which they can use at home, as you can see, and these are the various games the patient has played, and we can see the whether it's very easy for us to understand whether they are compliant or not, and how the visual acuity is improving. As in the graphs you can see, the logMAR vision acuity has improved from 0.45 to 0.1 at the end of therapy. So that's a 3-line improvement there. So the minute you look at the graph, you understand the patient is doing well. So coming to just for an idea about our results, we have done 74 eyes so far, and these are the demographic characteristics of the patients. As you can see, many of them, there are some of them below 6 years. If they are very intelligent and they can do it, we do enroll them. There are some patients aged 4 or 5 also. Many of them are between 7 to 10 or 11 to 19 age group. And so you can see here that before therapy, after therapy, all of them are having near binocular vision. 100% of the patients are having. And prior to the therapy, 6 patients had near suppression. After the end of the sessions, all of them had regained BSV. And for distance, initially around 74% had, and at the end of the therapy, 98% had gained distance binocular vision. 15 patients had suppression before the therapy. At the end of the therapy, only 1 patient had distance suppression. So there you can see the difference in distance. While near, many of them do have near BSV at the start of therapy, especially in anisoamblyopia. But at the end of therapy, you see that distance suppression has almost gone. And you see the stereopsis levels. Initially, only 9 patients had good stereo acuity levels. But at the end of therapy, around 33 patients are having near normal stereo acuity. or definitely they have improved a lot in the stereo acuity levels. Distance stereo also, you can see initially only 3 had some amount of distance stereo, but after therapy around 21 patients had normal, 23 patients had even like 120 to 480 stereo levels, and this graph shows the levels of improvement as to before and after dichoptic therapy. There are a lot of patients who had improved by levels like 1, 2, 3, 4 or 5 levels of stereo acuity after therapy. And you can see the improvement between the different types of amblyopia. Definitely ametropic and anisometropic amblyopia does very well. The best benefit would be in ametropic, but there is no other way of doing treatment in ametropic amblyopia. Just by wearing glasses, many of them will still remain at 612, they will still not have good stereo acuity levels. Ametropic amblyopia, once you enroll into any form of binocular vision therapy, they get very good improvement by 1 month. There are few patients with pseudophakics, but they were moderate amblyopia and they improved. Strabismic, once you align, we had pretty good results. And this shows the comparison of patching versus binocs. So those patients who are on patching therapy prior to the start of binocs, you can see in anisometropic we had 26 patients. In the initial, before starting occlusion, their mean visual acuity was 0.45. After patching for very many years, the acuity was 0.43. That is why we had started them on binocular vision therapy, because they were failed occlusion group. And you can see after dichoptic therapy, the mean visual acuity has improved to 0.26. So even patients who have failed patching, you can enroll them with the binocs or any form of binocular vision therapy. Ametropic amblyopia also, there is no effect of the patching is not done anyway. But after dichoptic, there has been improvement from 0.3 to 0.1. So, and ametropic amblyopia, they were wearing glasses for at least a minimum period of 3 months before we started them on dichoptic therapy. So, it is not just by the wearing glasses alone. Just by wearing glasses, they did not improve. That's why we had put them on dichoptic therapy. In the patients who were pseudophakics, similarly, similar to the, we can see from 0.33 to 0.30, but then after dichoptic, it has come to 0.1. Strabismic, for you don't see that much of an improvement, but you see from 0.62 it has come to 0.54, but there is some improvement. It is not like they didn't improve at all. So in the together all the patients, when you take, it was 0.46 to 0.44 after patching. After binocs it comes to 0.28, and we did follow up the patients for a minimum of 3 months after stopping the therapy. You can see that the visual acuity what we gained is maintained. Very rarely there is a drop by 1 line in our experience. Minimum of 3 months we have followed up, maximum to 1 to 2 years also. So they maintain the visual acuity even after stopping the therapy, which is very important. It's not a temporary thing. So you can see here, like 33 patients, 33 eyes, mean vision was 0.20 final, and after 3 months of minimum follow up it is 0.21. So not much difference. And similarly BSV stereo all are maintained. So this is again the same thing. The number of patients who had improved by 1, 2, 3 or 4 levels of vision or stereopsis following binocs amblyopia. The important thing is to choose the right patients. If you do not choose the right patients, you are going to dilute your results and you will say that it doesn't work. But once your inclusion criteria and exclusion criteria are well set, then I would definitely say that binocular vision therapy has a lot of advantage over the traditional methods of therapy. And technological developments, and maybe it is an evolving field, there may be a lot of improvements coming up in the future. And I think anybody who has further doubt or would like to know about binocs, I think the stand is it is there, the stalls are there. I can see Mr. Oliula also sitting, and any of you can contact him and he will be able to give further details on this. Thank you.
Thank you, Dr. Sandra. I just have a question to you. You're using the filters of red and green. Is it any
red and blue?
Red and blue. Is there any significance you should put in front of the amblyopic eye or anything like that, or
Yeah,
do you
red
reverse
before the
it?
amblyopia eye.
Uh-huh.
Red before the amblyopia eye.
And then you reverse it.
Yeah.
Any significance? How does it work? Like red, blue? Because we all are aware of red and green. Like that has been proved.
Oli, any comments on that? Why you have chosen the colors of red and blue?
If you
I
see,
think she's more curious about the blue part.
Yeah.
is that so? I don't know. I thought the red
Not
was very
the red
difficult.
part, but why? It's a form of dissociation.
In contrast to if when you have your even for your words for dot test, you have red and green.
Yes.
So if
The
you,
way they have designed the games, so that you want to reduce the contrast in one eye, and you want certain elements to be seen by the amblyopic eye and
so
certain elements to be seen by the
So
normal
you
eye.
said the red light, your red glass, you're going to put in front of the amblyopic eye.
Right. That only here. Sorry. Thank you, ma'am. So why we use these two color filters is just to dissociate two eyes. Now, why typically red and blue? Because it can be commonly available to the patient. And when we use these filters, the red is very difficult to suppress. That's why we put in front of the amblyopic eye, because it has a longer wavelength and you cannot suppress. And it also has a facility or the kind of stimulating the foveal cones. So that is another aspect we look at. So these are very good tools. And then blue, typically, because it is commonly available, we have chosen. But green is so we have a program where you can even choose the red, green. So always red is common, but either we choose a green or a blue filter.
Yeah, but the thing is, I think nowadays we are giving the filters to the patient
Correct.
along with it, because what happens is, if you ask them to choose, sometimes the quality of the red green glasses that we get is not uniform. It is very difficult to find a good pair of red green glasses. Even in our clinic, there are a lot of monocular clues available. So I would not suggest you to just buy something randomly use. It's always better to use something which is provided by the company, because if it doesn't work, we can always tell them.
No,
Yeah.
more typically when you do a Watford dot test in clinic, so predominantly if you look through the green filter, you would see all 4 dots visible.
Yes, yes,
And
that's why.
that is where you don't see a true dissociation happening and always false positive. Like you have suppression somebody, but unfortunately because
In
of
my
the green
clinic, there are now
filter,
10 pairs of red green glasses. There is only one that works.
one that was.
Yeah, right. So before checking on patient, always we have to see through that.
So that can be minimized with our program where we actually calibrate.
That means the quality of the product
Yes.
is not a standard
Yes.
product. So
Very true, ma'am.
we also have to see that we get quality products.
So we provide, along with the program,
okay.
we provide to all
Yes.
patients.
I think we are.
I think we are running late of time, so we'll carry forward the question. Thanks all for attending. Yeah.
Thank you for attending the instruction course.
Wait,